Hi, I'm Loretta Nastoupil from the Department of Lymphoma Myeloma at the University of Texas MD Anderson Cancer Center. It's a pleasure to talk about the role of bispecific antibody therapy in follicular lymphoma. I'm going to start with a case. This is a 54-year-old female who initially is treated with rituximab in combination with CHOP, following by 2 years of rituximab maintenance. This was 7 years ago when she initially presented with advanced stage, high tumor burden follicular lymphoma that was grade 3A. She experienced her first relapse and at that time was treated with bendamustine rituximab and is now relapsing 2 years after her second line approach. At this time, she's got adenopathy above and below the diaphragm. The largest lymph node is less than 7 centimeters, but is in need of therapy. She undergoes a biopsy and it does confirm recurrent follicular lymphoma. So, how would you approach this young, fit patient in third line? So for this first patient, she's a young female. She had had prior chemoimmunotherapy and is in need of therapy. And I think the biggest challenge for me is, do you pursue CAR T or do you pursue a bispecific for a patient like this? I like the idea of a bispecific because I know I can pursue a CAR T at a later point. And I think from a lifestyle standpoint, the bispecific is just a little bit more readily available. And if she achieves a complete response, we get to stop after 8 cycles. And so I think that's a little bit more intriguing, particularly for people who are working where they really don't want to take off that 4 to 6 weeks while you have to be monitored more closely for CAR T toxicity. And so she's in the midst of treatment right now. First response demonstrates she's in a complete response. So I'm pretty encouraged for her.
When you think about CAR T and bispecifics and FL, from your global point of view, how does sort of the plateau, if any, compare?
Yeah, we haven't seen the plateau in follicular that we've seen in large cell. So I do prefer CAR T over bispecific in large cell all day long. I think in follicular, the efficacy is quite high with CAR T, but the toxicity is not something that we ignore, particularly with axi-cell. Now, as we get a little bit more experience with T-cell, and if lyso-cell comes on the market, that may change my opinion. Where I prefer CAR T over bispecific are those patients who are behaving like transformed disease. I just didn't prove it with a biopsy, meaning they're POD24 or they're progressing quickly after a really good therapy. This patient went a long time, essentially after frontline, had a reasonable response after second line. So if it had been the flip, where it had been a quick, boom, boom, 2 good chemoimmunotherapies progressing quickly, I would have chosen CAR T first, because I think you probably do have a little bit better durability with CAR, but it's going to be a little bit more cumbersome, a little bit more toxic. A second case that I've encountered recently is a little bit different. Similar disease, but an older patient with comorbidities. So this is a 75-year-old male, has hypertension, type 2 diabetes, and mild chronic kidney disease, not uncommon for our patients, presents with symptomatic adenopathy. He was first diagnosed with low-grade follicular lymphoma 12 years ago, and at that time was treated with rituximab in combination with CBP, and was in an initial remission for 4 years. At his first relapse, he received single-agent rituximab for 4 cycles, followed by 2 years of maintenance. He remained in remission for 2 additional years. At his second relapse, he received lenalidomide in combination with rituximab, completing 12 cycles based off of the Augment study, another about 2-year remission, and is now relapsing. He's in need of therapy, again, older patient with comorbidities, a couple lines of prior therapy, including CD20 monotherapy, CD20 in combination with chemo, and lenalidomide rituximab. So how would you approach this patient? So this is an older patient with comorbidities, has had a number of prior therapies, but really hasn't had intensive chemotherapy. And so being really mindful of the toxicity. The other thing, you have to make sure that he's got good support at home, because if the cytokine release syndrome happens after hours, which it generally does, is there going to be someone there that's going to walk him through what to do? And so we did have a little bit of discussion back and forth. Is this the right therapy? And we ultimately decided to proceed. He's got good, social support. We had a lot of discussions about what to expect in terms of fever onset, what to do about it. He did have grade 1 CRS, and it did happen about 6 hours after the first dose. I give these patients my cell phone just so that they don't have to, there's no delays in terms of getting through the operator after hours. He called me right away. He took Tylenol. That went very smoothly. That was fine. The second dose, no issues. And just like you would expect, the third dose, he had CRS again. This time he was feeling a little bit more fatigue. We were monitoring his blood pressure. He didn't drop to where we needed to bring him in, but he was a little more ill with the third dose. We give them a prescription for dexamethasone just to have on hand. So we did go ahead and proceed with 8 milligrams of dexamethasone. We just needed one dose. He got through it just fine, no issues. He's also just had his first response assessment, and he's also in a complete response, which I'm pretty excited about. So it's just a little bit trickier during the first cycle because he did have toxicity, but we got through it quite well without any major hiccups. It's quite good. And then the third case is a 65-year-old female now relapsing with follicular lymphoma and in need of therapy. She initially is treated with bendamustine rituximab, but only has an 18-month remission duration. At her first relapse, a biopsy confirms both follicular but large cell lymphoma. We know that based off of the cohort out of Vancouver, there's a large number of patients who progress early following bendamustine rituximab that they have transformed, and so she's one of those cases. So her second line, she's approached with R-CHOP and remained in remission for 4 years. Currently relapsing and biopsy reveals only follicular lymphoma, so we presume that the large cell has been cured, but is now in need, after receiving lenalidomide, rituximab is in need of therapy again. So how would you approach this patient? In 65-year-old, don't mention any significant comorbidities, has the interesting finding of POD24 and a concomitant large cell lymphoma at one point, but now with just follicular. So this is a case that we're walking through the treatment options right now. I think in general, it's not an infrequent occurrence. And these are patients that are often excluded from trials. So I always want to put them on trial. But because of the large cell that happened at one point in time, she's not going to be eligible for a follicular lymphoma study. So then that removes the trial options from the table. So once again, you're kind of debating, do you do CAR T or do you do a bispecific? So this is one that I probably would pursue a CAR T first. I would do CAR in this one just because she's younger. She's had a large cell component at one point. And I would save the bispecific for if the CAR fails. So I illustrate all these cases because they're real life cases, but also painting a picture for where you might consider a bispecific antibody. And so first off, what is a bispecific antibody therapy? Well, this is essentially a therapy that engages tumor antigen and circulating T cells. What we'll be discussing today target CD20 and CD3. We don't know the exact mechanism of action, but essentially we think by engaging the malignant B cell and activating T cells that are in close proximity, you're going to essentially enhance the patient's own immune system to see and eradicate the tumor cells. There are a number of bispecific antibodies that are under development, and they do vary in terms of their construct. Mosunetuzumab was the first that was FDA approved for follicular lymphoma. Essentially, it has one arm that looks just like rituximab, and then the other arm engages CD3. Epcoritamab has an active FC region, so it's a little different. And glofitamab has a 2-to-1 configuration targeting CD20, CD3 engagement. And then there are BiTEs that don't have the IgG configuration. And I won't spend any time talking about AFM 13 today. So I'm going to kick off by discussing the pivotal phase 2 study that led to FDA approval of mosunetuzumab for relapsed follicular lymphoma for patients who've had at least 2 prior lines of therapy. That's because to qualify for this study, you had to have had 2 prior lines of treatment that included a CD20 antibody and an alkylator. Patients had to have a performance status of 0 to 1, and they could have grades 1 through 3A. There's a step up that's utilized with these bispecific antibodies to mitigate the most common toxicity we see in the first cycle, which is cytokine release syndrome. And you can see that mosunetuzumab's administered at 1 milligram on day 1, 2 milligrams on day 8, 60 milligrams on day 15. That's repeated a week later for the beginning of cycle 2, and then the dose is dialed down to 30 milligrams starting at the beginning of cycle 3 onward. There is a response approach to this, meaning for patients who achieved a complete response in the study, they could stop after 8 cycles. And for those who had stable disease or partial response, could continue out to 17 cycles. And 90 patients were treated on this single arm phase 2 study. Here are the baseline characteristics. It was over-enriched for those patients that were refractory to their last line of treatment. That's 69% of the population. 79% were refractory to prior CD20 antibody, and over half were double refractory, being refractory to both a CD20 and an alkylator. As I mentioned, the most common adverse event observed with these bispecific antibodies is cytokine release syndrome, because you're engaging patient's own T cells and potentially at a supraphysiologic level. I'll show you in the next slide a breakdown of when to anticipate the cytokine release syndrome, but that is clearly the most common adverse event we observe. That's followed by fatigue, headache, fevers that are not felt to be related to cytokine release syndrome. So you can see kind of a constellation of flu-like symptoms. Fortunately, there were no grade 5 or adverse events that were attributed to Mosin that led to death, and only 2% had adverse events that led to discontinuation. So this is generally quite well tolerated. The cytokine release syndrome is also relatively predictable in terms of onset. So you can see that about nearly a quarter will have cytokine release syndrome following the first dose. It's a little bit more common to have it after the full dose at day 15. Few will experience cytokine release syndrome with the second dose or with subsequent cycles. So this does appear to be something that we see much, much more commonly during the first cycle, and particularly after the first dose and after the full dose. And the median time to onset is important to recognize. It's going to be about 5 hours after the first exposure. And then 27 hours, so not when they're generally in the infusion center. So this does create some need for education, both in terms of the patient, the caregiver, but also the treating facility, because this is different from infusion reaction, which generally is going to happen during the time the patient's receiving the drug. About 8% received tocilizumab, which is an IL-6 blocking antibody. 11% received corticosteroids. So again, generally suggesting that these symptoms were quite manageable. Could you predict who's more likely to have grade 2 or higher CRS? So grade 1 CRS is essentially fever. Grade 2 or higher, now you're going to get into the realm of hypotension and or hypoxia, and that's going to require somebody to transition from an outpatient to an inpatient setting. So being able to predict who's more likely to experience grade 2 CRS would be very helpful, particularly as most of these patients are going to be managed in an outpatient setting. So we'll get more experience over time, but a couple clues here have emerged. Patients with bone marrow involvement are much more likely to have grade 2 or higher CRS. And again, something that would suggest these are patients that have more circulating CD20 positive cells that are going to trigger activation of those T cells. The durability of response looks to be quite favorable. Again, this is a single-arm phase 2 study. Important to recognize those patients who achieve a complete response have even longer duration of complete response. In median PFS is about 24 months. You can see about half the patients have hit the PFS event at the time of reporting of this study. You'll see updates most likely this year at ASH. We now have about 3 years of follow-up on this study. And again, the goal, in my opinion, is to achieve a complete response, because these are the patients that are likely to have quite favorable outcomes. Now, we've all been wondering, is this curative intent or curative potential? It's hard to really decide or conclude that that is true when you think about the natural history of follicular lymphoma. You don't really see a total plateauing of this curve. But again, those patients who achieve a complete response generally do much, much more favorably than those who achieve a partial response. And here's the overall survival for those patients who have a CR at the end of treatment, recognizing again that this was selecting out for higher risk patients. Again, quite favorable survival, particularly for those patients with a CR. Could you predict who's more likely to achieve a complete response prior to initiation of therapy? I think that would be lovely to be able to do that, particularly as you have a number of treatment options at your disposal, and we're all disappointed when it's unlikely or that we failed to achieve that complete response. It's a little bit hard given we're limited by the number of patients in the study, but you can see here those that had a CR at the end of treatment versus those who had not, a little bit higher percentage of those that were refractory to their last line of therapy, but similar percentages in terms of those that were POD 24. So, not surprising if you're progressing and failing to respond through a number of treatments, you're less likely to respond to your next treatment. But in general, I think this is quite favorable in terms of the other options that are available. And then, what about metabolic tumor volume? Or other ways to measure the disease burden and likelihood of achieving a complete response at the end of treatment. Really hard to draw any conclusions. If you look at this graphic from the study, it does not appear that the amount of tumor going in correlated with the achieving a complete response of treatment. So that's reassuring. So that tells me, even though I might be a little bit more concerned about cytokine release syndrome based off of tumor burden, I'm less concerned about the likelihood of achieving a durable complete response. So, in summary, mosunetuzumab is approved for patients with relapsed follicular lymphoma after at least 2 prior lines of therapy based off of the single-arm phase 2 study, which demonstrated quite high complete response rates that are very durable, including up to 2 years out, and no real strong correlation in terms of baseline characteristics that tells us this is going to be better for one given patient versus another. CRS was generally quite low in grade, which means it can be managed outpatient, and we do see low percentages of those receiving corticosteroids or tocilizumab, and maybe a hint at those with bone marrow involvement going into treatment are a little bit more likely to need those mitigating strategies or have grade 2 or higher CRS.
A couple of questions. First of all, I thought I saw a paper that you did or involved with suggesting a correlation between CRS and treatment benefit. Is there any correlation?
Not that we've really seen in large enough sample size. Now, obviously, when we're counseling patients about the potential toxicity, it's always reassuring when you see sort of a proof of concept or the toxicity that would sort of suggest that we're engaging those T cells and they're doing what we want them to do. But I don't think you need to see that and have confidence in the efficacy. I think some of it's going to be related to how much circulating tumor is present when you initiate the treatment.
Another question just, I don't know, occurred to me when you were presenting one of the cases. When you talk about POD 24, is that after the end of maintenance if they get it?
And it's been described differently across a number of series, but the first time it was described was from the beginning of chemoimmunotherapy, and that was generally the first treatment that was administered to those patients. Now, as we try to do a little bit better job enrolling studies, we've gotten more creative over time where we might count it from the end of treatment, but it was first described as from the beginning.
Right, and I remember that. Another question, what's the difference between a BiTE and a bispecific? Is it like the BiTE is not really an antibody?
Generally speaking, the bispecific is the full IgG antibody, and the BiTE, yes, it's not the full construct.
And another question, any issue about loss of CD20 in these patients? Do you look for CD20 before you use a bispecific?
That's actually a really good question. I think it's going to be posed more and more as we get more patients that are being considered for this treatment. On the study, generally you had to have CD20 either based off of a prior biopsy or going into the treatment, recent confirmation of CD20 expression. We don't know that you absolutely have to have, or what is the threshold for how much CD20 needs to be present to see activity. The problem is you've had more and more therapies that are targeting CD20. In my clinical experience, we do tend to see more emerging cases that lose that antigen or they internalize it temporarily. And anecdotally on these studies, we could actually retreat patients if they'd gone into CR after 8 cycles and stopped, and then they recurred. You could actually consider retreatment with mosunetuzumab. I had one patient on the phase 1 with mantle cell lymphoma that was true. She didn't respond when we retreated her. We got a biopsy to try and understand it, and she had lost CD20. She had it prior to the initiation of the study, but at the time of progression had lost it. So I do think that we'll see more and more situations where you will lose CD20, but I don't think you need to have it present or prove that it's present right before you initiate this therapy.
Just out of curiosity, for CD19 CAR T, do you need the CD19? Do you have to prove it's still there?
Generally, we don't, but again, where that might start to become more interesting is we see more CD19 directed therapy moving into earlier lines of treatment, such as things like tafasitamab or even loncastuximab. Theoretically, you could have either masking of that epitope or pressure, selective pressure for a CD19 negative clone to emerge. And so we've not faced that before, but that theoretically could happen over time. So the next CD20, CD3 bispecific antibody that I'm going to discuss is odronextamab, and that's because we've seen their pivotal phase 2 study, the ELM2. Again, it's a CD20, CD3 based off of an IgG antibody, so that does lend itself to less frequent dosing, but this has an interesting study schema. Again, ELM2 was one arm of a larger sort of basket study across a number of B-cell malignancies. This included patients with grade 1 through 3A follicular lymphoma, good performance status, who'd had 2 prior lines of therapy that included an anti-CD20 and an alkylator. So you're going to see a common theme emerge that appears to be sort of the unmet need in follicular lymphoma. What's unique about odronextamab was the mitigating strategies explored during their dose finding or recommended phase 2 dose schedule. And so what's meant by that is they went back to the drawing board after the study was put on hold due to cytokine release syndrome, that the rates were felt to be high, particularly those grade 3 or higher, based off of, again, small number of events. But they changed their dose step up to much less aggressive ramp up during the first cycle of therapy. And you can see outlined on this slide, they split the dose during the first cycle. So you have 2 doses on day 1 and 2 doses on day 8 and 9, and then 2 doses on day 15 and 16. And it's 0.2 milligrams on day 1, 0.5 on day 2, 2 milligrams on day 8, 9, and 10 milligrams on days 15 and 16. And then you get to full dose starting at cycle 2. Still dosed weekly. And then once you get beyond the first 4 cycles, then it goes to every 2 weeks at a maintenance dose of 160 milligrams. So it's just a little more complicated schema, but that was successful in terms of mitigating the CRS. And I'll show you some data to support that statement. But this is the sample size, 131 patients. Is a little bit larger sample size than the 90-patient single-arm phase 2 with mosunetuzumab. Similarly, you're going to see a high percentage of patients refractory to their last line of treatment, double refractory, and about 50% are POD24 status. The response rates were quite favorable. 81.8% achieved an objective response, and 75% of patients achieved a complete response. So again, quite favorable, particularly for this patient population. And when you try to look at specific subgroups to understand who was more likely to have a higher objective response rate, no real signals emerge other than maybe those patients that were older, a little bit lower response rate. But interestingly, again, those patients with low risk Flippy score had a very high objective response rate, but more consistent than not across all of these subgroups, you see responses with odronextamab. This is dosed until progression or intolerance. So it's a little bit different than mosunetuzumab, which is a fixed duration treatment. And with about 2 years of follow-up, the median PFS is about 20 months here. Again, we don't really see any plateauing of these curves, but there was a good portion of patients who had a complete response that did stop after a year as a result of clinician or patient discretion, suggesting that people felt pretty confident about the complete responses being more durable and not continuing on indefinite treatment. I think that's an important question that's going to continue to emerge, is what is the optimal duration of treatment with these therapies given the response rates are so high. Similar to what we saw with mosunetuzumab, cytokine release syndrome is one of the most common adverse events observed, followed by neutropenia, and then some of the other flu-like syndromes. Fortunately, most were low grade. Again, there were a number of grade 3 or higher adverse events, but once they adjusted the dose step up, there was only one grade 3 adverse event. So essentially cut the percentage down quite dramatically just with that change during the first cycle. Again, small portion receiving tocilizumab and corticosteroids, suggesting that this can be done safely. Now, the difference between this therapy and mosunetuzumab is there was mandated hospitalization during the dose step up. So essentially, each time patients underwent a dose escalation, they were monitored in an inpatient setting. So it'll be interesting if this drug gets FDA approved, what the label will suggest in terms of guidance. So in summary, odronextamab, again, another CD20, CD3 bispecific, has a very high objective response rate, quite favorable complete response rate, and it does appear to be durable with a median progression-free survival of about 20 months. Now, to be critical, that's not much different from the PFS we see with mosunetuzumab. That's a fixed duration of treatment. So again, questions have been posed. Do you need that extended dosing? Does it really translate into a difference in terms of ongoing durable remissions? And so the company is now exploring fixed duration treatment, a little bit different than mosunetuzumab. It's not response approach, but more just a time limited therapy, which I think will make it a little bit more attractive. Epcoritamab is a subcutaneous bispecific antibody, again targeting CD20, CD3. It's now currently FDA approved for diffuse large B-cell lymphoma, not yet available for relapsed refractory follicular lymphoma. One interesting aspect of this agent is we haven't seen the single-arm phase 2 data with epcoritamab and follicular lymphoma. We've seen phase 1 data across a number of B-cell non-Hodgkin lymphoma subtypes, including follicular, and it looked promising in a small number of patients with follicular, but we're seeing their combination data emerge. And this is an example of a combination with rituximab and lenalidomide. The idea behind it is that you take therapy that's going to be effective at engaging endogenous T cells and NK cells with the addition of lenalidomide, partnering it with rituximab because that's a proven combination, and then adding epcoritamab. One question that's been posed is, do you need rituximab since you have a CD20 targeting therapy with epcoritamab? And again, what's unique about epcoritamab is the FC region is not silent, so potentially they could synergize or at least have additive activity, whereas you wouldn't expect that with something like mosunetuzumab. Again, good performance status was required to qualify for this study, and they did include grades 1 through 3A. The schema is outlined here. Lenalidomide and rituximab were dosed similar to the AUGMENT study, with epcoritamab essentially given weekly during the first cycle, 1 to 2 cycles, and then every 4 weeks from cycles 3 through 12. And then after the combination with lenalidomide rituximab, it's continued for another 2 years. So again, extended dosing. Here are the 76 patients that have received this combination. Get enriched for high-risk patients in terms of more than half having FLIPI of 3 or higher. Not quite as refractory as we've seen with the other studies, about 38 to 39% having primary refractory or double refractory. But again, looks to be very well tolerated. What's intriguing is when you add other agents in, you tend to see lower rates of cytokine release syndrome. We've seen this with mosunetuzumab when it was partnered with lenalidomide. So that's an intriguing observation. Neutropenia continues to be an adverse event that we see associated with these agents, but fortunately, we don't see that translate into high rates of infection or febrile neutropenia. And the rates of fatal treatment emergent adverse events were low. 3 essentially patients in this study, and they were all due to COVID-19. I think that's another question that we sometimes pose with these bispecifics, given you're going to have prolonged B-cell depletion. Viral infections is something that you just need to be on the lookout for. Again, 43% had any grade CRS. All were grade 1 or 2, and all were seen at day 1 of cycle 1. And then when the full dose was achieved, very low rates beyond that. response rates were very favorable, particularly when combined with lenalidomide and rituximab. You can see here nearly 84% of patients achieved a complete metabolic response. Short follow-up here at the time of reporting was only about 6 months, but the vast majority of patients still remained without a progression event, suggesting this efficacy looks to be quite good, though early. So the conclusion from this is you can definitely combine a bispecific with something like lenalidomide and rituximab, achieve very high response rates. Actually, the safety looks to be quite favorable, maybe even more favorable than single agent if we'd seen much single agent data with epcoritamab and follicular lymphoma. And now, most likely, this is just going to move into earlier lines of therapy. So this was studied in the relapse setting, and we have seen data now emerging in previously untreated. So the last antibody I'll talk about is glofitamab. Again, it's a 2-to-1 configuration of CD20 to CD3, again, approved for treatment of relapse refractory diffuse large B-cell lymphoma. We have seen data with glofitamab monotherapy or in combination with obinutuzumab in patients with follicular lymphoma. One unique aspect to glofitamab, obinutuzumab is administered 1 week ahead of initiating glofitamab in an attempt to bind up CD20 circulating cells in an attempt to mitigate cytokine release syndrome. And we know obinutuzumab works quite well in follicular lymphoma, but you can see here response rates with glofitamab monotherapy or in combination with obinutuzumab, and they're quite high. We do think that maybe that 2-to-1 targeting of CD20 to CD3 makes it a very potent antibody, and so efficacy is going to be quite high. And here are waterfall plots demonstrating, again, the vast majority of patients had reduction in tumor volume from the initiation of therapy. Again, relatively short follow-up. Cytokine release syndrome is going to be something we pay close attention to with glofitamab. It does have some of the higher rates of CRS, including those that are grade 2 or higher compared to the others. Again, that may just speak to the fact of the configuration. With the obinutuzumab administered prior to initiation of therapy, that does help mitigate this, and you have a similar dose step up as the other agents. So to summarize, glofitamab can also result in very high response rates. The trade-off is you're going to have a little bit more cytokine release syndrome, though again, it's going to be manageable. Most is going to be during the first cycle. And with step up in obinutuzumab pre-treatment, you can mitigate most of those grade 2 or higher. Where are we headed next? Well, we do have randomized studies that are underway. The Celestimo, which is mosunetuzumab in combination with lenalidomide versus R-squared, is completed enrollment. So we're anticipating we may see some of that data emerge in 2025. Odronextamab is moving into combination strategies, including into frontline. Epcoritamab, again, we should see the single-arm phase 2 data emerge, and there are a number of combinations that are being investigated, larger sample size with R-squared, both in the relapse setting and the frontline setting. So I think where we're headed with these is mostly in combination and into earlier lines of treatment, and the efficacy looks to be quite favorable. If the additional agents add to that, then I think you really could go head-to-head and challenge your chemoimmunotherapy, which has kind of had a mainstay in the frontline approach for follicular lymphoma. So I'm excited about where we're headed next. So to conclude, I think the bispecific antibodies are one of the most promising therapies that has emerged recently in follicular lymphoma. There is an unmet need for understanding the cytokine release syndrome in terms of onset and management, but most patients will have low-grade CRS that can be safely managed. I do think it will likely have more of a role than CAR T-cell therapy because it's more readily available, and I anticipate that we'll start to see these agents move into combination in earlier lines, and so there's still going to be an unmet need for understanding how we sequence this therapy, but I do think this is going to be an effective option for a number of patients.
Interesting. One other thing, a more global thing I was just thinking about as you went through the talk there, which is the sort of differential activity of bispecifics in FL versus diffuse large B cell. So it looks like indirectly comparisons, at least in diffuse large B cell, I can see the response rates are not quite as high. What about the other way in terms of the glofitamab and EBCO? In terms of FL, and what do you think is going on biologically that some of these seem to do better with diffuse large B cell, some FL? Like, what do you think the variables are?
That's really interesting. So I think in general, CD20 targeting has always been a very effective strategy in follicular. And we used to think a lot of it was how much CD20 was on the surface, but I think part of it too is just the tempo of the disease. And so follicular just is much less proliferative. And so it gives your immune therapy really a shot at it. Whereas sometimes with large cell, you have these patients that are just progressing so quickly, you just really don't have a chance. And you kind of need that cytoreduction so that your immune system can keep pace with the disease tempo. And even with CAR T, we see that. With follicular, you don't have that obstacle at all. So by and large, the response rates are going to be much higher. The flip side of that, we have much less tolerance for toxicity, though, because we want all these patients to live a really long time. So if you have any treatment that results in the need for hospitalization or puts them at risk for septic shock or puts them at risk for any treatment emergent grade 5 toxicity, we're not going to tolerate that at all. So we anticipate high response rates, but almost equally important is what is the downside in terms of quality of life, toxicity, and if it's, really cumbersome, we'd have zero tolerance for that because there's so many other options. So I do think there's more of a social component to it. I think that the disease tempo lends itself to more immune therapy, so that by and large the responses are higher. But the perfect example is GlowFit versus Mosin. I don't really see a future for GlowFit and follicular just because the toxicity is higher. The efficacy is probably also a little bit higher, but Mosin's good enough, and the ease of use is so much greater that I would choose Mosin over GlowFit all day long in follicular.